Good afternoon, everyone. I'm Tom Glinski, Chief Inspector with the Board of Pharmacy, and welcome to our webinar today. Our topic is Pharmacist Naloxone Dispensing. Our speakers today, we have two presenters during the program. Kimberly Grinston is the Executive Director of the Missouri Board of Pharmacy, and then Kelly Gable is Associate Professor at Southern Illinois University at Edwardsville School of Pharmacy. She'll be giving a section of the program today. And then at the end, we'll be taking questions, and we do have Angela Wilson here today from Mo Health Net to answer any questions related to Mo Health Net related to naloxone. We'll talk about the different options for dispensing naloxone in the state and explain the new statewide naloxone standing order that became effective back in August. And then, as I said, we'll answer questions at the end. If you haven't been on our webinar before, there's a toolbar that will show up. If you have trouble connecting over the internet to the audio, you can dial in using the access code provided on the toolbar. All participants are in listen mode only, and you're muted. This has been approved for 1 hour of CE. You must be officially signed up and logged in to the program. If you're in a room with multiple people under one login, only the person who's logged in will be getting credit. We do not issue credit for those just dialing in over the phone, listening to the phone. At the end, there'll be a survey and you have to take in order to get your CE. I'll go over more instructions about CE at the end of the program. And just a reminder that the Board of Pharmacy does not submit to the CPE monitor, so if you need CE, you'll get a certificate, and you may need to save your certificates. We posted handouts of today's webinar. They're on our website, on our homepage, just in the area where you announcing how to sign up for the program. There's now a link to the handouts. We will also be making a recording of the webinar. You can find all our past webinars and this one under our publication resources section of our website. There's no CE for watching recordings of webinar. We will be taking questions at the end of the program. If you'd like to submit a question during the program, just go to your toolbar, type in the question, and hit send, and we'll get it here, and we'll hopefully be able to address it at the end. So now I'm going to turn it over to Kim Grinston.
Thank you, Tom, and good morning to everyone. Well, actually, good afternoon to everyone who's joining us on the webinar. We have a lot of important information to share today. As you heard, the Department of Mental Health is here to discuss some of the mental health issues related to naloxone dispensing and the new standing order. Before we do that, I wanted to give you just some general information about the new law and about the new requirements that are in place. For those of you who were on our legislative update webinar, some of this information may be the same, and or who may have been at meetings recently where we presented on the new standing order, but we will be adding in new information. We will have new information from the Department of Mental Health, and also Mo Health Net is here to answer questions you may have. So let's just begin with some basic information. Senate Bill 501 was passed this year by the General Assembly. It became effective August 28, 2017. It allows pharmacists to dispense naloxone under a statewide protocol or a standing order without a prescription. And so pharmacists who are dispensing under the new standing order are not required, or a prescription is not required to dispense naloxone. The statewide protocol or the standing order was signed by the Department of Health's director, Dr. Randall Williams, who is also a medical doctor, and again, it became effective August 28th, 2017. For those of you who may not know, the standing order is available on the board's website, so if you have any questions about the standing order, please visit the board's website. We also did or published the August newsletter. Many of you should have received the August newsletter in the mail. If not, it is on the board's website under publications and resources and also under news. It contains more detailed information about Senate Bill 501 and dispensing naloxone under the standing order, including information from the Department of Mental Health. Some of the basics of Senate Bill 501, again, it authorizes any Missouri licensed pharmacist to participate in the standing order. Unlike a protocol, the standing order is not an individual contract or agreement with an individual physician. Instead, any pharmacist can dispense and or sell naloxone under the standing order, subject to the restrictions and quantity limits identified in the standing order. And that is, of course, without a prescription. One of the things about Senate Bill 501, in the passage of Senate Bill 501, the goal was to make naloxone readily available. So by statute, no additional pharmacist training or certification is required to participate under the standing order. So unlike immunizations, unlike MTS, unlike administration by prescription order, you do not need to file anything with the board. You don't need to notify anything with notify the board, nor do you need to complete any additional pharmacist training. I think we saw by statute the legislature really recognizing the training and education that pharmacists already have as medication experts. The physician protocol, you guys may remember that last year we had legislation passed that allowed dispensing of naloxone under physician protocol. That language is still in place, and so if you'd like to dispense by protocol, that is optional. However, the standing order now allows any Missouri licensed pharmacist, if you're a pharmacist licensed by the board, you're allowed to dispense under the standing order with or without a physician protocol. The standing order allows dispensing to any eligible candidate, and that definition is very broad. You see just a really brief summary here on this slide. It generally would apply to anyone who voluntarily requests naloxone, and that should read and is at risk of an overdose or is in a position to assist someone at risk. That definition was left intentionally broad by the Department of Health because, again, the goal was to make sure naloxone is readily available to persons who may be in need. Quantity limits are established in the standing order. Please see the standing order on the board's website. The standing order provides that when naloxone is dispensed or sold, patient education is mandatory. And if you look at the standing order, it requires patient education on the signs and risks of an overdose and what to do in the case of an overdose. There's information for many of you who don't know. The board has a naloxone resource page on its website that has a lot of information and brochures that could assist with that patient education. In fact, the board has developed a brochure that you can request from the board's office in limited quantities that can be given to patients about naloxone dispensing and also about signs and risks of an overdose. The Department of Mental Health, though, has established a wonderful resource page, and many of our resources come from the Department of Mental Health and link to the Department of Mental Health. It really is a complete and very good resource for patient education and also pharmacist education. And I need to back up just really quickly. We talked in previous slides, and we indicated that no additional pharmacist training is required. However, pharmacists should make sure that they are educated and aware of how naloxone is dispensed and or administered so that we make sure you are giving patients the best information. Senate Bill 501 gives you the option of treating a naloxone sale or dispensing as a prescription or as a distribution. So again, you can dispense naloxone as a prescription, which would require a patient name. Well, not require a patient name, but it would require a prescriber. And that for the standing order would be Dr. Randall Williams. And I mentioned patient name. I'm going to come back to that in a minute. But you can also treat the sale as a distribution. If it's a prescription, you have to comply with all prescription requirements. That would include two-line format. If it comes in as a prescription or if you're creating a prescription in your records, you want to make sure you're recording the prescriber, what was dispensed, and the name of the patient. However, patient name is not required, and Department of Mental Health is going to talk with you about some barriers to dispensing, and what to do if a patient refuses to give a name. If a patient refuses to give a name, the board has taken the position that this is really in a pharmacist's discretion. If a patient gives a name that you might suspect might be false, the goal is to record the dispensing if you're treating it as a prescription, and so we would ask that pharmacists use their discretion when documenting who a prescription is issued to. If you're treating as a distribution, patient name is recommended again, but not required. It's recommended but not required. The board does recommend that you document some basic information in the event of a sale. Things like the transaction date, the product name, strength, and dosage form, and the quantity. That would be important in the event of a recall. Distribution records are maintained for 2 years, and prescription records should be maintained for 5. One of the many questions that we've received about Senate Bill 501 is how do you bill for naloxone? We've been asked if the state will provide a free supply, and I think the Department of Mental Health may have some updates on that. But from the insurance side and or the billing side, every insurance plan is individual. We've actually consulted the board office with the Department of Insurance, and the Department of Insurance has explained that coverage will depend on the individual plan. They are recommending that pharmacists check with insurance companies to determine what to do if someone comes and is insured. Will their insurance company cover naloxone, and what are the limits? Just like any other prescription, you would check with the insurance company. MoHealthNet has announced that they will allow reimbursement, and again, we have a representative from MoHealthNet here today to talk about some of your reimbursement questions. We've received questions in the board's office on things such as what happens if someone comes in and requests naloxone and they are insured and they request naloxone for their son. They have insurance, but they will use it for their son or a child or maybe even a friend. That may not be part of their coverage plan under insurance. Unfortunately, this is not a question that the board can answer and would really depend on what the insurance company allows and what the insurance company accepts. We have heard that several insurance companies will not allow it to be billed that way if you know the product is not for the insured that is presenting at the pharmacy. But again, this is going to be an insurance question. I would stress, though, that pharmacists still have the option to dispense it or to sell naloxone as a distribution. So let's say you have an insurance problem, insurance won't cover it for whatever reason, you can also always sell the drug as a distribution as well, of course depending on if they're able to financially afford it. That's just a general summary of Senate Bill 501 and what the law requires. I will be taking questions on the new law again later on in the webinar. But at this time, I'd really like to turn the program over to the Department of Mental Health, who has really led the initiative in responding to the opioid crisis that is currently in Missouri. And also, they were influential in providing direction on the implementation and the promulgation of Senate Bill 501. We have with us Kelly Gable. She's the Associate Professor at SIU East School of Pharmacy. She's been working with the Department of Mental Health on Senate Bill 501 implementation and other opioid-related efforts. She's also a pharmacist. At this time, we will turn this over to Kelly, and again, we will be available for questions for either myself or Missouri HealthNet later on today.
Okay, thank you very much, Kim. I am going to get my slides up here. And we are ready to go. So I am so glad to be here today, and I'm so glad that you are on the call to learn more about naloxone. I'm going to switch gears for a moment and talk more about the clinical use of naloxone and questions you might encounter in the pharmacy, and hopefully we'll address some of those common things that I've heard thus far from pharmacists. And if not, I would love to answer any questions that folks have along the way. So I'm going to flip to the next slide here, which is talking a little bit about the state targeted response to the opioid crisis grant. And that's really what Kim mentioned that I'm actively involved with. And this is $10 million per year for potentially 2 years in direct response to the opioid overdose crisis that we are facing, not just in the country, but really specifically in Missouri. And I want to point out that our statistics as of now say there were 908 opioid overdose deaths in 2016 in Missouri. And we also recognize that there are pocket areas, specifically in the St. Louis City and County region, that we want to be really mindful of. I also want to mention that fentanyl, or a derivative of fentanyl, was the main overdose cause of overdose deaths nationally in 2016 and also in the St. Louis region. So we know that this is a continued ongoing problem, and this is really a wonderful opportunity for pharmacists to get involved and hopefully reduce the amount of deaths that we're seeing. This slide really highlights the sites for naloxone distribution. Within the grant that I just spoke about, they will also talk about and administer and dispense or disperse naloxone through the jail system, obviously through methadone clinics and through primary care clinics. Another arm of this, however, is community pharmacy. And we recognize that the community pharmacy is such a beautiful place for someone to go in and ask for naloxone, because all communities have a pharmacy and access to the pharmacist, and it's a wonderful way for someone to feel hopefully comfortable to get access to a life-saving treatment. I want to draw your attention just quickly to the results of a recent survey that came out through the Board of Pharmacy. And this was prior to the statewide standing protocol. And so you probably remember answering these questions. So this came out either via email or some of you got a phone call about this. And I do want to point out just a few things that stood out to us. Up here you can see, does your pharmacy currently have a protocol in place to dispense naloxone without a prescription? So this was, again, prior to the statewide standing order, and there were 873 that did not. This is an opportunity, I hope, for a lot of pharmacies to really jump in and now fall under that statewide standing protocol. So I'm hoping this is a really good opportunity. I also want to point out the next question, number 3, was, do you have naloxone in stock in your pharmacy today? And 522 answered no. And this is another really big take-home point that we want to make, is that it's really critical for pharmacies to stock naloxone, and so that when someone does come in to ask for it, you have it handy and ready to go when they ask. Because the odds are if someone leaves without it, they may not be able to come back, and they may die, or their loved one may die before they're able to come back. So that was another really important piece that stood out to us. And then finally, on question number 5, does your pharmacy currently provide training specifically towards naloxone? And as you just heard, the training's not required, but we really strongly recommend that you offer training to your pharmacy staff as well as technicians and frontline folks, because those will be the individuals who will respond initially to questions about naloxone. And so there were quite a few, 820 that said no, and this is an opportunity to say that we offer free training across the state, but really focused in the St. Louis region for pharmacists and technicians and interns if you would like to learn more, and I'll talk more about that at the end. So the next question I get a lot is, who should receive naloxone, and how do I know if it's a right fit for this person? And so I do want to walk through just a good example of someone who would be an ideal candidate for naloxone, and this is Lisa. She's a 50-year-old female who was diagnosed with several different medical conditions, including fibromyalgia, generalized anxiety, chronic back pain, and sleep apnea. And that becomes really critical in the naloxone's necessity. She receives treatment from multiple providers, and including coming to see you on a regular basis. She sees a PCP, a rheumatologist, and a psychiatrist. She frequently overtakes her pain medication to get control, and you can see she has quite a few medications on board here that are of concern. And the biggest problem here is that Lisa has never been talked to about naloxone. And so one might ask, who should talk to her about it? Should it be her primary care provider? Of course, it should also be the pharmacist. And that's our hope, is that after this statewide standing order protocol is in place, you feel much more comfortable to talk to patients about this and to offer it to people who really are in need of it. So Lisa falls through the cracks, and she's someone who is at a significant risk for an overdose, most notably noting that she has sleep apnea, and she's also taking a benzodiazepine as well as an opioid. And so that goes to the next slide, which is who should receive naloxone. And some of these are from the CDC guidelines and also from a JAMA publication in 2014. The CDC guidelines tell us that anyone who is receiving an opioid dose that exceeds 50 morphine milligram equivalents a day should be offered naloxone. Now, despite that, someone who's receiving less than that could also overdose. So we could also say that anyone exposed to an opioid should receive naloxone, but absolutely anyone receiving over 50 morphine milligram equivalents. Anyone who's receiving a benzodiazepine plus alcohol, and again, that's the respiratory depression risk, and anyone who's using heroin. If they come to you and they tell you they're asking for needles, these are opportunities to offer naloxone up to that person, or hopefully if they're asking for it, they're able to get it easily. The last one on here, number 7, says recent release from an opioid treatment program, jail, or hospital. These individuals are at higher risk as well because their tolerance to whatever they may have been using may have dropped when they were in treatment or in the hospital, and they are at a very, very high risk of potentially an unintentional overdose. So those individuals are also, we want to be mindful of them. Now again, I asked who should receive naloxone, and joking but not really, it's a trick question because anyone who comes in and asks for it, who's at risk of having an opioid overdose or who is at risk for witnessing an opioid overdose should be offered naloxone. And that's really, across the board, a statement that we want to say pretty strongly. And so I'm going to take just a few more minutes to talk through some common questions that I get that will hopefully set your mind at ease with regards to naloxone dispensing. So a big one I get is that I'm just not comfortable talking about overdose with my patients, and I'm not sure what to say. I'm not sure how to even bring this topic up. So this is a nice segue. This is a nice dialogue that this pharmacist is having with the patient when dispensing an opioid. It says, I'm recommending that you get naloxone today. The medications you are taking can cause slowed breathing or even death. Naloxone is an antidote that you can keep on hand to reverse this situation. If it's okay, is it okay with you if I provide you with naloxone today? Or you can say, can I talk to you about naloxone today? Any of these work, and I hope that you noted that there were specific things that were avoided in this dialogue and in this conversation, most notably the word overdose. Now, overdose can be a really tricky term that we use, and sometimes it can really scare people, especially if they have not witnessed an overdose or if they're not injecting or using heroin. So for someone taking prescription opioid medications, avoiding the term overdose may be advised, and we may want to use something like this can slow your breathing, or this can be a really risky medication sometimes that's prescribed, and this naloxone is an antidote that can help if you need it. Here are some other ways to start the conversation. So I'm not going to go through all of these, but I do want you to just take notice of some different ways you could bring up this topic. Could we talk for a minute about your medications that you take for pain? Has anyone ever talked to you about what you should avoid while you're taking your Vicodin or your oxycodone? Has anyone talked to you about how to stay safe while taking your pain medications? And that's a beautiful segue into harm reduction and naloxone. And then you can offer resources. There are so many resources now, and I'll direct you to some more when we get to the end, that you could potentially offer up to your patients. And then also you could even go just directly into, would it be okay to take a moment to talk about what happens if you overtake or take too much of your pain medication, or if you're using heroin, why I'm worried about that and why this could be a concern. One thing I would like for you to do is really think about what you might be comfortable to say to folks that you work with, and really recognize that when you start this conversation, you let your patients know that you care, and that is such a wonderful thing for someone who is struggling with addiction or maybe is looking for ways to recover. So just letting someone know that you care and that you're a part of their healthcare team. So the next question is, how do I know which naloxone product to dispense? So as some of you know, there are 4 different products that are out there, and so hopefully we'll make this pretty easy for you. These are the 4 different options for individuals. And so I'm going to go down each column, and I'm going to start with the first column and say that this is the older product system that's been used for a very long time, often used by EMS. And this actually is a intranasal kit that as a kit itself is not FDA approved, but separately you can purchase an atomizer. The atomizers are sometimes not available through manufacturer, and that's one concern we have with this product. However, this is my understanding, it's in the statewide standing order, and insurance would vary in terms of coverage for this product. The next one is the naloxone Narcan intranasal spray. This one's highlighted in red because this is a very practical one that you will likely stock and use quite often or dispense quite often. And it is very easy to use. It is currently covered under MoHealthNet, Missouri Medicaid. And the highlighted in darker bold red, the 4 milligram per 0.1 mil is the dose that you would dispense. and it comes with two intranasal devices, and all products actually come with 2 doses that would be delivered apart from each other by about 2 to 3 minutes. And then the next one is the Intramuscular Kit. This has, again, been used for a very long time. These are the vials. So these would be the 0.4 mg per mil vials, and you would dispense 2 along with your syringes. And again, this is very cheap, or cheaper than the other products, and so valuable in that regard. But if people have a dislike to use needles, or perhaps they are not familiar or comfortable with needles, that may be a discouragement for this one. And then finally, the one that's not highlighted in red on the far right is the auto-injector, and it is really user-friendly, and it talks to you similar to other devices like epinephrine or EpiPen. It is quite expensive, and so for that reason, it's also not in the statewide standing order and not covered by a lot of insurance companies. So that would vary based on the provider, the insurance provider for that patient. Okay. So the next question is, are there specific things that I should say when I dispense naloxone? There's lots that can go into this piece, and I will say that all of this information is available online and through the Board of Pharmacy website. But I want to cover a couple important things. And so the answer is yes. Of course, there are things that you should say when you dispense naloxone. Number one is that naloxone is not self-administered. It is not administered by the individual who's overdosed. It's administered by a friend, a family member, or a caregiver. So it's important that we are clear about that. Some people may not be clear. And so we are not administering naloxone to someone unless they are in a true opioid overdose. So we want them to understand what an opioid overdose looks like, and I'll talk more about that in just a moment. So we identify the overdose, and again, if the friend, family member, or caregiver can be present in the pharmacy to hear this dialogue, that is wonderful. If not, we want to convey to the patient that someone else needs to understand this information too. We identify the overdose. Now, some providers actually recommend that naloxone be administered next. If the person is very aware that this is an opioid overdose, administer naloxone, call 911 for help. Other individuals will recommend identify the overdose, call 911. And again, this may vary depending on the region that you live in and how quickly emergency response happens. Regardless, 911 should always be called. Then perform rescue breathing if needed, and then you can administer a second naloxone dose in 2 to 3 minutes if there hasn't been a response. Always recommend or encourage someone to stay until help arrives. So whoever administered the naloxone needs to stay with that person until emergency personnel arrive. So those are the 5 steps that we always want to talk through with the patient who's receiving naloxone. And these are also, the next slide, this is under the sample Missouri protocol template for pharmacists on naloxone dispensing. So under the Board of Pharmacy resources, all of this information right here is listed. And so this is exactly, gives you a walkthrough of what you should cover with the patient. So again, the risk factors for an opioid overdose. You want to talk about administration. So if you are dispensing the intranasal, the Narcan intranasal, you talk about how it is administered versus the injectable. Any side effects. Now, really what you're going to talk about here is that when someone is administered naloxone, they will go through anywhere from a mild to a more moderate or severe opioid withdrawal syndrome, and that is really the reaction that you see when someone is administered Narcan. So there really aren't a lot of tolerability concerns. It's more so opioid withdrawal experience. And for most people, it's fairly mild. If someone does not go through an opioid withdrawal and they do not respond to Narcan or naloxone, then it is likely that they've taken another substance that may have contributed to the overdose. And so you also want to talk about storage at room temperature and the expiration of the product. And finally, and the importance of calling 911, but we also really want to be mindful of our words that we use and really trying to avoid using stigmatizing terminology, such as addict or user or the term overdose or abuse. So being really careful with our words and what might be more welcoming for someone who's coming in, and they may be very scared, or it may have taken a lot of courage for them to come into the pharmacy to ask for the product. And so the next question is, I'm busy and I'm not sure that I have time to do all this, because it does feel overwhelming. It feels like a lot of information to cover in a short amount of time. And so the encouragement here is that it really does just take about 5 to 10 minutes to go through all of this information. And once you do it several times, you become really skilled at it. And 5 to 10 minutes is worth potentially saving the life of another human being. And so with that brief 5 to 10 minute interaction, what you can cover is what an overdose would look like. And so this is just the quick and dirty. With an opioid overdose, you will notice the pinpoint pupils, and the person will not be arousable. By shaking or calling their name, they will not arouse, and you may do a sternal rub. And for those who are familiar, your knuckles are rubbed against your chest, and you do that very hard. And some of you may even want to practice to get the feel of that's a really hard way to arouse someone, and if they're not responding, then that's indicative potentially of an overdose. If their breathing has stopped, or if their breathing is less than 8 breaths per minute, and if you see blue lips or fingertips, that also tells you the lack of oxygen supplied to the body and extremities. So these are all signs of an overdose. We want the person who's getting naloxone, as well as their caregiver, person that lives with them, person that they may use with, they need to know what the overdose looks like as well. Because again, the person who's going through the overdose will not be administering naloxone to themselves. All of this in 5 to 10 minutes you can get someone comfortable with the product. You can loosely demonstrate how to administer naloxone and make sure they're comfortable with that, answer any questions that they have. And also you can allow them to, or you can have that dialogue about what an opioid overdose, how that would look different than a cardiac arrest or a myocardial infarction, or potentially an overdose with some other product. Okay. How does naloxone really work? Wouldn't someone just take more opioids if they had access to it? This is a really, really important question to address. I hear this sometimes from other providers, but I also hear it a lot from the lay public. And it's really important that we address this. It's called risk compensation concern. And so what we know now is that studies demonstrate that providing naloxone in a harm reduction fashion actually decreases opioid-related emergency room visits and overall opioid overdose-related deaths. There's no evidence to indicate that the majority of individuals follow what's called risk compensation. And so what that means is a good comparator that I like to use is wearing your seatbelt. And I think that this really resonates well with people if you make that comparison to just because I wear my seatbelt doesn't mean that I drive my car faster. And there are plenty of other risk compensation examples you could use, such as providing vaccinations as preventative for sexually transmitted infections. And so this really helps people to understand that, oh, okay, if I do wear my seatbelt, I'm not necessarily going to drive faster. There may be a couple people that do, but the majority of people do not. And so I'm providing naloxone to someone as a way to prevent something bad that could happen, but I'm not planning for that bad event to happen. And I won't read this fully, but there's a quote on here from a pharmacist in Massachusetts, which has a really large harm reduction initiative, and he just makes that comparison to having a fire extinguisher in the house. And you have a fire extinguisher in your house. We all do, not because we want our house to burn down or because we want our house to have a fire. We do it because an accident could happen, and we want to prevent that or reduce the risk of it. So that's a good, solid way to address naloxone stigma and risk compensation. And then I want to close out with a few other things that we hear along the way. These are some myths and truths about naloxone. So the first one is that naloxone is a competitive antagonist at opioid receptor sites. And of course, the answer to that is, turning green, it is true. Naloxone is a competitive antagonist at opioid receptor sites, and that's exactly what we're using it for. The sole purpose of naloxone is to use it when someone has overdosed with an opioid. We want to disperse the opioid from the opioid binding sites, and so that is exactly what it is. It's been on the market for a very long time. The next question, it reverses analgesic, dysphoric, and other pharmacological effects of an opioid. And I told you earlier, of course, that is true. And this is part of the issue. When you give someone naloxone, yes, of course, they will go through an opioid withdrawal syndrome. And so they will experience pain if they were experiencing it before, and any other pharmacological effect of the opioid will be reversed. And that's the beauty of it, because it's also saving their life. It's also restoring their respiratory function. It is effective at reversing an overdose with benzodiazepines, barbiturates, or stimulants? And the answer to that one is, of course, false. It is not effective at reducing anything else from an overdose except for an opioid. And so we want to be clear, if someone has taken multiple other substances, that they still are at high risk. And again, the importance of 911 being called and emergency providers being present. It has been FDA approved and used by EMS to reverse opioid overdose for over 40 years. And some of you may be surprised, or maybe not. It is true. It has been on the market. It has been available for a very long time. And so naloxone is not new to the medical system, but it's new in that it is now available more widely to the lay person. And so that's what's changed over the last 10 years. It is the same thing as naltrexone, which is a long-acting opioid antagonist. And of course, many of you know that that's not true. However, that is a common misconception that people have. It is not naltrexone. Naltrexone is not used in acute situations. It's a long-acting injection that we use for long-term treatment of either alcohol or opioid use disorders. So we want to be clear that we don't want to interchange, or we don't want to hear the patient interchange the term naltrexone and naloxone, because they are different. And then finally, it has minimal interaction in the body without the presence of opioids. And this is very true. So if I were to administer, or if naloxone were to be administered to me and I had not taken any opioids, I would not have a physiological response from the administration of naloxone, and that is an important thing to note as well. It is a widely known safe medication that would not harm me if I had not used opioids. Okay, and so we're almost to the end of my portion. These are just some consumer-related barriers that I would like to point out. And this was all pulled from a published study and survey data in Rhode Island and Massachusetts. And I think this is very important information. It comes directly from the consumer. And so what we now know about obtaining naloxone in the pharmacy is that there's some embarrassment about coming into the pharmacy. It takes a lot of courage to come in and ask for this product. There may be a fear of consequences if I ask for it, or that I may be labeled as a criminal or someone who's misusing medications, when in actuality perhaps I want to keep my child safe, or I want to keep a family member safe, or I want to make sure that I'm okay as I try to work through my recovery. So there's a fear that comes with this. There's a fear of getting tagged and labeled as some of the terms that we want to try to avoid. And there's a lack of public knowledge that naloxone is readily available at the pharmacy. So now we all know this. It's our job to disseminate that information out to the public and let people know that they can come into the pharmacy, that they can ask for it, and they can readily get it. And also there's misinformation that naloxone is only for someone using heroin. And we want to be really clear that it's not. It's for anyone who has exposure to a high-risk opioid medication. And so last question is, will I get in trouble if I dispense this without a prescription? And of course, you now know the answer. It was covered very well at the beginning of the webinar, which is no. Missouri Senate Bill, 501 covers the statewide naloxone protocol, and just for your own information, it also covers the 911 Good Samaritan law. And I like this quote that is up here on the side, which is that 80% of heroin users inject with a friend, which is weird because 80% of overdose victims found by paramedics are all alone. And part of this is that we do not want people to leave the scene after they've called 911 because of fear of prosecution. So the 911 Good Samaritan law offers immunity from arrest, charge, prosecution, and conviction if you call 911 during an overdose. So that's an important piece of information that we can disseminate to people when we pass out or disperse naloxone to hopefully get people to stay with their person until EMT or EMS arrive. So I'd like to leave you with thinking about what barriers you see for yourself with regard to naloxone prescribing and dispensing. What concerns do you have? What barriers do you see? And hopefully we can address some of those. As I mentioned earlier, we offer free expert training, and this is through the State Targeted Response to the Opioid Crisis Grant. I would encourage you to contact Lauren Green. She's our Overdose Prevention Project Coordinator through MIMH, and her email and phone number are listed here. Send her an email if you are at all interested in learning more, or if you would like an in-person training of your staff or an online program, we are happy to offer such trainings. And then I also want to point out some resources that have already been talked about. If you haven't already taken a peek, go to the Missouri Board of Pharmacy website. The naloxone standing order is at the front. And if you scroll down, you can also go to naloxone-specific resources that are very, very helpful. Prescribe to Prevent is one of the resources that is listed here, and I'm going to pull it up because I want you to see. This is a really helpful website. Prescribe to Prevent has been available for a very long time, and it has information for prescribers, pharmacists, patient education, research, and advocacy. It is an incredibly helpful resource to have at your fingertips. And also, Prevent to Protect is actually a pharmacist-specific resource. So it stems off of Prescribe to Prevent. So I would strongly encourage you to check that one out as well. If you're interested in the theory and practice of harm reduction, I would encourage you to check out harmreduction.org. And I mentioned helping people direct them towards treatment. The last link on here is the Substance Use Treatment Locator through SAMHSA, and that can be a really useful resource as well. If people are struggling and you are at a loss for how to help, this can be a way that you could offer them finding resources in your area. And that is the end of my section. I think maybe we'll have a few more words, and we'll have it open for questions.
Okay, thank you, Kelly. We will switch over to questions in just 1 minute. If you have any questions, go to the toolbar on the side, and you can submit them, type them in there, and hit send, and we'll get them here. We're ready. I'll read off the questions. Kelly, we do have a couple here that would be directed for you, so I'll let you know when they're your questions. So here's one for the Board of Pharmacy. Just to make sure I understand properly, a pharmacist can write a prescription for naloxone from the standing order. Is this correct?
And the answer is yes. You can write a prescription. Dr. Randall Williams would be listed as the prescriber. I think this next one's for Kelly.
It is. The question is, what is the likelihood of an intranasal product working if someone has already stopped breathing?
Oh, the likelihood is very high. That's actually, there will be situations where someone has stopped breathing, and so they would get their first dose intranasally. And I also get a question of, if they're not breathing, how are they? You don't have to breathe in the drug. The drug gets sprayed up into the nostril, and you wait 2 to 3 minutes, and then you would administer dose number 2. So the odds of response hopefully would be very high if given within the first few minutes of ceased breathing. So yes, that's exactly what you want. You want to regain respiratory function. It's a good question.
Someone's asking if we know the average cash price for IM naloxone, and we do not know that, so we would not be a good source for that information. Kelly, this one is for you. Is there evidence of naltrexone, long-acting opioid antagonist, being useful in fentanyl overdoses?
That's a good question, not to my knowledge, because remember, it is a long-acting delivery system, so I would not feel comfortable recommending it in acute situations. You would have concerns with someone giving naltrexone, taking it for, let's say, alcohol use disorder, and then also prescribed an opioid. But the risk would be that the opioid pain medication just wouldn't be as effective. But no, I would not use that to reverse an overdose.
And just to clarify, the standing order is just for naloxone also. We have a clarification. Is a patient name required if using a prescription to provide naloxone? The answer is yes. If you're doing it by prescription, you must have a name. If you want to sell it just as a distribution, a name is not required. But if you're creating a prescription, you would need somebody's name there.
Someone has asked if the director of the department changes, does that change the new standing order? Senate Bill 501 says that the standing order can come from the director of the department or from a medical doctor authorized by the department. So right now, we don't believe that a change will automatically void the standing order. Should that happen, we of course would provide additional information. Someone has asked if a school can obtain naloxone under the standing order. The standing order right now applies to persons. It does not talk about dispensing just to entities. That doesn't mean, though, and we talked about this actually at a meeting this weekend, that doesn't mean that if you may not be able to dispense to the school district, but if the nurse came in and said, would you just sell it to me, you could always do it as a distribution to the individual nurse in the nurse's name, or just to the nurse as an individual, but the standing order itself doesn't mention entities.
I would also add, I've been told that Adapt Pharma, which makes naloxone Narcan, offers a limited supply to colleges and universities for free.
We have someone asking if we have talked to the State Board of Nursing in regards to administration of naloxone by RNs and LPNs.
We have not. I know that we have representatives from the Board of Nursing on the webinar today, but no, we have not talked with them specifically on that. Doesn't mean that we won't.
If someone wants to know, do pharmacies have to report the naloxone they dispense to anyone, the board or anyone else?
And the answer to that is no. You should be maintaining distribution records, but you don't need to report to the board. Please, we don't want a bunch of reports coming into the board office. Statute doesn't require it.
Have there been any conversations with the State Board of Healing Arts in regards to altering prescribing practices?
That's an interesting question. The Board of Healing Arts and the Board of Pharmacy will be co-sponsoring an opioid safety conference in the early winter or early part of next year to talk about just this issue, safe prescribing practices from the prescribing standpoint, and also how that interacts with pharmacy. Pharmacy will be there, and we have asked the Board of Healing Arts to include conversations on why does the pharmacist keep calling me, things that the prescriber should be looking for. Because I think a lot of times, and we've heard this from our licensees, a lot of times our licensees are asked about opioid overprescribing, and we always get the question, has anyone talked to the doctors? So yes, we will be doing that and actually holding a joint statewide conference to discuss just that issue with prescribers.
Kelly, here's one for you. They're asking, when would intranasal naloxone 2 milligram be recommended?
As of right now, I would say you would not recommend the 2 milligram dose. There's different controversies and talk about why they would have 2 and a 4 milligram dose. I think the 4 milligram dose should always be used because of the risk of someone having been exposed to carfentanil or a higher potency opioid. So right now, we would always recommend the 4 milligram dose.
Can we use the standing order to dispense to a fire department or other entity?
I think that goes back to the same answer. The standing order doesn't reference entities, and so I think you can get to the same place a different way. You can't dispense to the entity, but if the office manager or someone else just said, sell it to me, and then they took it back to the entity, that would be allowed under the standing order. And you would do that as a sale, of course.
They want to know if they can get the standing order physician's address. It's not on the protocol, so we'll have to get that. I would assume it would be the department's address.
Yes, I think we would want you to document the department's address. Didn't realize that out. We'll send that out on our e-alert, but in the interim, I would just use the Department of Health's address in Jefferson City, and we'll post it on the board's website. That's a good question. Hadn't come up before.
Since IM syringes require prescription, are they part of the protocol when dispensing the IM vials? The answer is yes. The protocol does say, if you look at the protocol, it lists what other items you need to give out, and it does list that you need syringes to do that.
There's a question here. It's a bit of a legal question. It says that there's a law in Missouri that requires the prescriber to physically see the patient. How does that work with the standing order? Since Senate Bill 501 was passed by statute, it would be presumed to modify that requirement, and it allows Dr. Williams to issue the standing order, even though obviously he wouldn't be seeing all the patients, and it allows pharmacists to dispense. So I think legally, for purposes of Missouri law, that wouldn't be a problem.
We have someone asking about, I guess they spoke with their liability insurance provider. They had concerns about dispensing without the name of the intended person. Does the Good Samaritan law cover any liability we are exposed to?
It does. The Good Samaritan, well, I should say it is very broad. It covers a lot of situations. It basically exempts pharmacists, healthcare providers from civil and criminal liability if you are dispensing in good faith. Now, that doesn't mean that won't impact the way your liability insurer may cover you. So if you had a claim, it doesn't mean that you may have some issues with being covered if you don't have a patient name. I would talk with your insurer about that, but the Good Samaritan law does say that you cannot be held criminally or civilly liable for actions related to, good faith actions related to dispensing naloxone.
What documentation is required for distribution or sale?
Right now, we don't have any mandatory language on that. The board is recommending that you document the transaction date, the product name, strength, and dosage form, and the quantity. And of course, distribution records have to be maintained for 2 years. So that's just a recommendation from the board. And that's if you haven't had a chance to see the August newsletter, that is in the newsletter.
We got a couple questions related to Missouri Medicaid, so we're going to let Angela answer those. The first one is, if Missouri Medicaid covers the prescription for naloxone, does Dr. Randall Williams have an NPI number for Medicaid?
Yes, he does. He is an enrolled MoHealthNet provider.
And his NPI number is on the standing order under his signature. His DEA number and NPI number are printed there if you need that to get them into your computer systems. And then you just answered the next one. Does he have his own Medicaid provider number?
Yes, he is an enrolled provider.
Okay. So, someone is asking, do you need to include lot number in your distribution record?
We don't have a requirement on lot number. If you choose to document it, that's fine, but it's not required and/or currently recommended. One of the mandatory recommendations of the board, or the suggested recommendations, of the board.
Someone's asking if they can have a copy of the presentation. If you're talking about an actual copy of the PowerPoint, email me and I will see what we can do if we're able to get that out. We do have handouts available on our website if you're talking about just a paper copy of it. We have a question is, if you're doing distribution, does this count towards the maximum 5% without having to be registered as a drug distributor?
This is a legal question that the board talked about at one of their recent meetings. The law is not very clear on how the 5% limit it would be applied in these situations. However, given that the statute allows the dispensing without additional licensure from our board or a pharmacist training, at this time the board is informally advising that a drug distributor license is not required. Should that change as the board legally reviews the requirements, we would of course let pharmacists know, but right now the board is not legally requiring a drug distributor license for those absent further review or until further review.
We have someone's asking to see Lauren Green's contact information, so I pulled that screen back up for that person. We have someone asking, can a pharmacist working for correctional facilities obtain naloxone for inmate patients at individual jail and prison facilities?
I don't know how that would work with the Department of Corrections, but from the standing order standpoint, a pharmacist would be considered an individual who would be covered by the standing order and could purchase naloxone for an individual inmate or anybody else at an institution. That wouldn't be prohibited under the standing order.
Can a pharmacist administer if an overdose is happening at their pharmacy?
This is one of the tricky things about Senate Bill 501 and even the statute that passed last year. The statute doesn't specifically address pharmacist administration of naloxone, but it does say that if a person administers naloxone or assists someone who has been administered naloxone, they are exempt under the Good Samaritan law from certain criminal and civil liability. So I think the statute definitely suggests that pharmacists, just like any other person, are covered by the liability exemption under the Good Samaritan law. I would caution you to check with your insurance companies and also to check with your corporate policy to see what is allowed. But should a pharmacist administer in good faith, I think it may be covered by the Good Samaritan law as currently enacted.
The question is, should we always dispense 2 of the IM 2 milligram per 2 ml? Some of them come as 1 dose. The standing order tells you to dispense 2 of everything, so the answer would be yes.
Someone has asked if a patient presents and cannot pay, what is their recourse, who pays, or how will the pharmacy be reimbursed? It's an excellent question. Of course, you would need to work with the insurance company to see if it's covered. MoHealthNet gave you coverage information today as well. Right now, this is not something that the board can answer, but Kelly, I would pose this question to you. I know that the Department of Mental Health is researching the possibility of possibly supplying some naloxone resources throughout the state for certain entities and or individuals. I know that that research is still underway. Can you provide us any updates on that?
Right now I can only say that we're still waiting to work out details with Adapt Pharma. So no news yet, but we can absolutely let folks know when we have more information.
Someone's asking, will we be conducting the webinar again? We will not be conducting it live, but we do make a recording of it, and it will be posted on our website so you can rewatch this or show it to other individuals once it's posted on our website.
I think we're getting towards the end of our questions. Kelly, it's almost 1 o'clock. Do you have anything that you'd like to end with or add before we finish our webinar?
I think I would just echo again, I really appreciate everyone's attendance. This was a wonderful attendance for a naloxone presentation, and I hope you learned what you needed to, and if you haven't, please reach out, like I mentioned, to Lauren Green. And again, if you have questions about any of the clinical utility of naloxone, we are here to answer them. That's partly what the grant funds, so please reach out to us.
We have one last question came in. With the prescription written for a standing order, would be allowed to have any refills? The standing order actually has that covered in there. It says refills. I think it says PRN. Hold on, and I'll pull it up.
It does say PRN.
PRN, okay. Yeah, it says PRN. So that would be good for a year under Missouri law. So we're now ready. We're going to end the webinar or go over the continuing education instructions again. Once I tell you that I'm closing the webinar, a little screen will pop, a little window pops up that says the webinar has ended. You click close, and then a survey will open up. You need to answer the questions on the survey in order to get CE. If for some reason you have trouble getting the questions to pop up, you can send an email to compliance@pr.mo.gov, and we will email you those questions. If you get the questions in that manner, you must have the answers back to us within 48 hours if you want to get CE. We will mail out certificates in approximately 30 days, and again, we do not report to the CPE monitor, so keep a hold of your certificates. And again, we will be posting a recording of the webinar. Last time we did it within 2 days, I believe. We put here 30 days, so check back within a couple days because the last one went much quicker. So we are now going to end the webinar, and you all have a good afternoon.
Thank you for attending.
Thank you.